Hello, colleagues registered for the 2022 AMEC Summit, whether you're in person or online. I'm sorry that I could not be in Vienna for this important event on evaluation of communication. However, I'm pleased to be able to share with you some key findings and learnings that I and my research colleagues have gained in evaluating the public health communication of the World Health Organization over the past 2 years. And as I say in my title slide, these are learnings from an organization at the epicenter of an existential crisis in which effective communication has been a matter of life or death in some circumstances. So I believe that this provides us with a very important case study that will be useful for you. So when we look at the work of the World Health Organization over the past 2 years, we see a number of quite important external challenges. And the first obvious one is the virality of what officially is known as the coronavirus, or the SARS, the severe acute respiratory syndrome, coronavirus number 2, known as COVID-19. It is spread around the world with enormous speed. That in turn has meant that the World Health Organization and health authorities have had to act very quickly in response, both at a medical and clinical level, but also in communication. And they've had to do that globally. The other challenge we've faced, as you know, is that the coronavirus has not been standing still. We've had to face numerous variants, from the very first alpha variant that came out of the Hubei province in China, and then a beta version that was found in South Africa, then the very virulent Delta virus, followed by Gamma, and of course most recently we've had Omicron, both BA1 version and BA2. And I put a question mark because we're still in a situation in which there could be further variants of this fast-moving pandemic. We've had other factors such as what I call the Trump factor. And as you'd recall, in the early days of 2020, the former President of the United States, Donald Trump, made a number of statements about the virus and about what he called cures that were very led to what the United Nations went on to refer to the fact that coronavirus was not only a virus, it was in a pandemic, it was a infodemic, and eventually it also became labeled a disinfodemic, which further added to the challenges. And then, of course, we also faced an anti-vaccination movement. So there were many challenges that we were facing externally. There's also, though, a number of internal factors that will interest you from the organizational perspective, and how we would go about communicating and how we'd go about evaluating our communication. Just in setting the scene, I wanted to just note the resources that the WHO has. We were reporting, and I must say my work and my colleagues' work was as independent researchers, so I'm not speaking on behalf of the WHO. We were brought in as independent researchers to evaluate, working with the Department of Communications, the DCO in Geneva, where there's a number of very competent and very dedicated staff. As well as communication staff, the WHO has an enormous number of technical staff who actually provide the medical and clinical information, as well as policy advice. We also work with IT staff because much of the communication obviously was digital. And we work closely with WHO has 6 regional offices around the world, also with communication staff. And the point I just wanted to make is, to set the scene, is that the WHO is clearly not a small organization, and it's also not an uncommitted organization. It's a United Nation that's an organization with a high level of dedication and commitment and passion to deliver effective public health communication. For example, to back that up, the WHO has a strategic communication framework that's a published document, and in that it also has extensive web pages that outline principles and guidelines and models for conducting evidence-based communication. This is just one example of a web page where you see it's a page dedicated to evaluation, and it talks about the purposes of communications evaluation. And you won't be able to read the type on this web page, but I've just highlighted that in that page on evaluating campaigns, the WHO recognizes that it's not only about doing activities and putting out outputs, but outcomes and impact of communication are critical. So evaluation is very central to the work of the WHO. This is the WHO program logic model for communication that is in those web pages. And you'll see that it's a classic 5-stage program logic model that identifies inputs to planning, activities, outputs, outcomes, and finally impact. And the web address and my slides will be available for those who inquire to AMEC. It gives the address of this model. It's a very intelligent model that it does recognize something we all grapple with, and that is that impact is often long-term, and also communication is only one factor that contributes to impact in many cases. And that's represented in this model. But what is critical in this model is that under the bracket of communication at the top, you will see that it's not only about inputs and activities, and it's not just about outputs, but the model is clearly showing that communication must produce outcomes to be effective. A final thing I'll show from those web pages is that under the banner of Communicating for Health, the WHO identifies its audiences and many key partners, and clearly its audience includes every individual in the world potentially, but also communities and groups, and very specifically healthcare providers, international health organizations such as national health authorities, policymakers. So there's a very wide range of stakeholders and audiences. So let me get into the detail of the challenges we faced and what we did in terms of evaluation. Challenge number one is that the organization, because of this crisis, because of the need to respond quickly, the staff were very focused on getting information out. If you can recall the early days of 2020, just when the pandemic was being declared as a global pandemic, the WHO was under enormous pressure to publish web pages, publications, produce fact sheets and brochures, produce videos, and so on. And so understandably, there was a huge focus on doing activities and producing what we as communicators know as outputs. And I'm sure many of you share that same pressure in your organizations. The challenge in that was that evaluation was seen as an ex post activity, something you did at the end looking back. And that leads to the problem that evaluation is often seen negatively. It's seen as accountability. It's seen as reporting to justify what you did. And in many such circumstances, communicators then question the value of historical information. Is looking back very useful? And also there's a fear of failure. And so this was one of the things we had to address. And so our response was to meet MEL. We changed the language from measurement, which we often talk about, and even measurement and evaluation. We changed the terminology to measurement, evaluation, and learning. And all through all of the work we've done over the last few years, the discussion is always about MEL. And I'll talk about why that's important. Measurement, of course, is, in very simple terms, simply taking measures to obtain data. So on its own, unless we do something with the data, measurement is an important first step, but it's only a first step. Evaluation is when we interpret what that data means and we make judgments on our progress against our objectives. But there's something more in our view, and that is we need learning, because learning is about gaining and applying insights that can improve, initiate, and innovate. So those insights flow into future strategy and tactics. But very important, so this led to this model MEL, and all through our work we talk about the MEL model rather than measurement, and rather than measurement and evaluation, where measurement's data collection, evaluation is analysis and the reflection, and learning is about replanning, refining, and improving. And a very important part of that is there's two dimensions to the learning in MEL. We need to learn from measurement and evaluation. We need to get those insights that they provide the value and they look forward. But in order to learn from MEL, we also need to learn about MEL. And so again, we applied these two dimensions of learning from and learning about measurement and evaluation, and I'll give some examples. Challenge number two is, in very simple terms, there is an organization-centricity in much of the work in the measurement and evaluation industry, if I can use that term. This is the well-used evaluation framework of the UK Government Communication Service. And Alex Aiken leads measurement and evaluation in that organisation and does a very, very good job. But you will see that the ultimate stage is called organisational impact. It's also the same even when we look at the AMEC framework, where the final stage is referred to as organisation impact. Now, when we come to the World Health Organization, they, of course, are interested in societal impact. What about our stakeholders? What about communities? What about society? And so this was also one of the challenges that we faced, that we needed to shift, and I believe our industry needs to shift the focus from just looking at what our organization wants to achieve to looking at the benefits to society, to our stakeholders, to the economy, and so forth. And we're reminded when we look at the definition of communication, because it's not to be confused with transmission of information. That's just one part of communication. Communication comes from the Latin noun communicatio, which actually means sharing, having things in common. The Latin verb communicare means to share and make common. Dictionary definitions talk about communication as exchange. John Durham Peters, a famous writer, talks about that it's imparting information, but it's also exchanging information. And so this two-way approach is very, very important. That led us then in our strategy to adopting a different model, and this is one of my own frameworks from a book I published in 2018 called Evaluating Public Communication. And all we've done here is we've kept the same 5 stages of inputs, activities, outputs, outcomes, and impact. But the arrows are the key part of this model. The arrows represent the information flow. And certainly information comes down from the organization, but you'll see by these arrows that a lot of information, we're drawing information from our stakeholders and from publics. At the input stage and setting objectives, we should be bringing in information to understand audience needs. Yes, activities and outputs, the information flow is outwards. But when we come to outcomes, this is when it changes again. We have to be listening to our audiences to know what the outcomes are. Now, I'll come back to that and talk more about how we bring in that information and why it's important in a moment. But the WHO certainly was not without information. In fact, Challenge 3 I refer to as the data mountain, and some of you may encounter this. At the same time, we had too little data and we had too much data. What do I mean by that? Well, we already had website statistics that many website statistics using Google Analytics. There was social media analytics that we could develop internally. The WHO in the past few years has been using not one but 2 global media monitoring and analysis companies that each produced a lot of information. We had intranet statistics from internal communication. We did internal staff surveys. We also had some public third-party data from the likes of the Edelman Trust Barometer. We had technical reports from WHO staff who were working with national health authorities and healthcare organizations. We had regional office reports. So what we had, though, was lack of data integration and analysis. All of these different data sets and data and reports existed in the organization even before we arrived, but they were not integrated and we could not make sense of it. And so what we had to do to address this challenge was what researchers refer to as meta-analysis and metasynthesis. Even before we produce new data, we had to look at all the available data sets and bring them together in some way. Now, meta-analysis is simply a term that refers to combining and reanalyzing quantitative data. With qualitative data, you don't have numbers. We refer to metasynthesis, where we're synthesizing multiple qualitative findings to look for consistent patterns and trends. And what we did from this meta-analysis and metasynthesis, where we were looking at all of the data sets and refining it and breaking it down, we're able to produce dashboards to simplify and combine. And many of you would be familiar with dashboards. In the dashboards, we combine traditional and social media quant data, traditional and social media qualitative data like sentiments and comments, website statistics, stakeholder feedback when we had it. But, and here is a weakness and a challenge we met, is that we were lacking data to identify outcomes and impact. Here is an example of one of the dashboards that was produced, and these were produced weekly, as you can see, during the critical period. And I won't go through all the detail, but just to point out that there's a column charts in the center there. You'll see they refer to sentiment analysis in media. There's key message penetration in the top left. There's share of voice in media. There's even regional breakdowns of web visitors and so forth. But when we come to look at outcomes and impact, there was very little data that we had to put into those boxes. So we knew a lot about what was going out, and a lot about was appearing in the media and online, but we didn't really know what audiences were doing with that data and that information. Challenge 4 added to this complexity, and I'm calling it industry misevaluation. And this is a somewhat controversial point that I'd like to offer back to the industry, and something we need to think about. Here I've de-identified the media analysis companies, so we're not defaming anybody. But this is one of the media analysis companies that were reporting to the WHO, and this is their description of what they reported as impact. And the text will be too small, so I've blown it up here. And they cite impact as based on the credibility of the source, the audience reach, and the relevance of the article to a company and a topic. And so this is a secret proprietary algorithm that they use to calculate what they call impact. And what you'll see is there's a subjective judgment on what is source credibility. Media reach is a hypothetical number of how many people could possibly have seen an item. And the media content relevance is related back to the organization, but doesn't tell us anything about what the audience thought of or did with that information. So this is quite bluntly not impact. It is not a measure of impact. It's misreporting impact. It's actually a measure of media content, both quantitatively and perhaps qualitatively. The second media analysis company, also de-identified, had a different way of doing it, but this was even more simplistic. In their reports, they identified their impact simply based on the volume of media mentions. Now, I hope there's no one out there who thinks that simply the volume of what we put in the media is our impact. Yes, media is very important, but the word media itself tells us something. We are mediating. It's the channel between our organization and the audience. It is only the channel in between. Impact has to be happening in the audience and in society or in the economy. And so this practice is what is known as substitution error that I just wanted to briefly talk about. And here's a quote: "The common error in program evaluation is substituting measures from one level for those at another level." And I've highlighted in red that this statement was published in a public relations textbook way back in 1985. So we've known about this problem for a long time. Jim Gruning, a very famous PR professor, is a bit more specific, and he says that substitution error involves a metric gathered at one level of analysis to show an outcome at a higher level of analysis. So we're using something like an output measure to claim it's an outcome or an impact. The very famous Don Bartholomew, the late Don Bartholomew, also quoted in his book as saying many public relations professionals regularly get their outputs confused with their outtakes and their outcomes. And so what you're seeing and what we were seeing in the WHO data that we were getting from the evaluation suppliers was substitution error. And typical examples are quoting media impressions as an outcome, or media sentiment as an outcome, or using secret algorithms to calculate some score that purports to be a measure of outcome. What this led to, and I loop right back to my point on learning, is that this led us to the conclusion that we had to do a lot of capability development with our colleagues in the World Health Organization. We had to develop internal learning so that we could receive and gain and generate the right levels and the right types of data. Some of the things we did, we conducted over the past 2 years a whole series of MEL workshops online, where we went through all the different methodologies and methods and models of what is appropriate. We produced a 70-page MEL manual that is in a PDF form, but is now going online as an interactive tool, full of tools and tips and guidelines on how to do valid measurement and evaluation. We found many people, you'd be surprised to know many people lack time. And so we do micro lessons, short 5 to 7 minute videos on key steps. And you'll see in the top right there, me on video talking about key steps in MEL for communication in a micro lesson. We work with the WHO, not just doing the evaluation, but advising them on setting smart objectives, advising them on what are appropriate KPIs, key performance indicators. And this is an ongoing program of learning. And I really have to take my hat off and endorse Alex Aiken's comment. And this is a tweet of his online last year where he said, "We should never stop learning." Here, Alex Aiken says it, and we also found this was critical in the World Health, even in a United Nations high-level, very effective organization. We need to keep learning. Now, when we talk about learning, very often academics like me get accused of being too academic. So I just wanted to share quickly with you a couple of examples of the learning we provided internally to show how we made some of it very, very simple. Here are 2 simple tests to avoid substitution error. In other words, simple tests to decide on what's an outtake, what's an output, what's an outcome or an impact. First one I simply call the doer test. And that is, we ask the question, who is doing the thing you're reporting? That bit of data you're reporting, who's doing it? The second one is the site test. We ask the question, where is that occurring? Where is that action or piece of data coming from? And this will make sense when I show you an example in what I call a dissected program logic model. So here is going back to a program logic model and I've left inputs off this model just for simplicity, but you see there's activities and outputs leading to outcomes and to impact. And all I wanted to show here is that when we're doing activities like writing, monitoring social media, or producing outputs like posts online, impressions in the media, sentiment in media, these are things that practitioners do. The doer test is we are doing them or we are arranging them. Even if they're in the media, it's still not the audience doing them. We're organizing it with the media. And so the doer test says they are things we do, and the site test says they are things that are occurring in media platforms. They are on the way to audiences, but they are not there yet. They are in media. Outcomes are what the target audiences do. When we ask that question, who's the doer? It's something target audiences do, like online engagement, likes, retweets, shares, click-throughs, statements of support. And the site test says all of those kind of metrics are occurring in the audience. They are evidence of receipt and response. Evidence of transmission or sending is something we are doing, so it's an output. Impact, of course, are things that occur in industry or practice, the economy or society, flowing on from our communication. And so the printed version of that model is available, the dissected program logic model that's presented in a slightly neater form. But what it does, it clearly says, and I've included inputs here, inputs and activities occur in our organization. They're things we do. Outputs are things we create and do, but they occur in media, as you see at the bottom. Outcomes are things that occur in our audiences or stakeholders or publics. They are evidence of reception, reaction, and response. And our impact is what happens as a result downstream in society, industry, or in policy sometimes, or in the economy. And I certainly hope that these kind of tools and models are useful because they provide a very simple checklist, 2 simple questions. Who's doing it? Where is it occurring? And that leads me into the 5th challenge was we really, as I've said before, lacked audience data. We had mountains of organizational data and mountains of media data, but we didn't have a lot of audience data. So our final challenge addressed last year and this year has been to generate audience data. And the first thing we did was we introduced omnibus and third-party survey data. Now, you may think the WHO is a big organization, has a huge budget. No, like many organizations, it has a restricted budget and we have to spend it wisely. So many of us can do this. We turn to third parties like the Edelman Trust Barometer, who kindly agreed to include a question on the WHO in the last 2 years. We turn to organizations like the Pew Research Center, the Johns Hopkins Center for Communication Programs, who included questions about the WHO in a number of their studies. And this was a low-cost way of doing it. And this is just one example of some of that data coming in that we were able to compare our media exposure with trust and to also geographically locate it around the world to see where trust was lowest and where trust was highest. As we move forward in 2022, though, we are going further, and to get to that level of outcomes, to find out what audiences think and do related to our communication, we are now introducing key stakeholder and key informant interviews, where we are talking to senior officials in national health authorities, senior staff in healthcare organizations. We're asking them questions about, are they using WHO information? Do they think people believe it? Are people accessing that information? Do they see people responding to WHO information? We're also planning public surveys in 2022 and 23 because ultimately, to understand awareness of WHO information and messages, to understand the use of WHO materials or your organization materials, you've really got to be asking your audiences. So you might be wondering what has worked and what has not worked. Some of the things that have worked: credible spokespersons. I think we would all know this, very important. Dr. Tedros, the Director General, the likes of Mike Ryan, Maria Van Kerkhove, very important credible spokespersons is critical. We've also found, though, that science has worked. We've worked incredibly closely with leading scientists such as epidemiologists, and because that provides credible data for people. But also we've got to reach down to people who are not necessarily into science or even talking to doctors. And so we've used an influencer strategy where we have recruited various experts and celebrities, not only epidemiologists, but we've recruited sports stars. We recruited Lady Gaga. When Lady Gaga went on stage and said, "Wear a mask, guys," millions of people said, "Okay, I'll wear a mask." And so influencer strategies are critical. But also the credibility of national health authorities, localizing the message down to local health authorities in various countries, and even right down to local doctors and local health workers to spread the word. We did this because if any of you have read the Edelman Trust Barometer last year or this year, the latest one, at the very top of the trust list at the moment are scientists. And so clearly we've been using that, but you'll also see there national health authorities and people such as that in the high trust list. And so looking at this, it's not much use using those on the left. Even journalists are not trusted in many parts of the world. So we really have to question our media centricity and our focus on media and look at where trust resides. We also found short, simple explanations of science are important, not heavy explanation. And we produced a series of what are called Science in 5, where we took a scientific issue, could be vaccine efficacy, and had explained it in 5 minutes. We also found, and this is a very interesting one, we found a whole of WHO approach, and this was a term we generated as an insight from our research. It's very easy to become focused on a crisis like COVID-19, and in the early days of the crisis, all the focus was COVID-19. But we had Donald Trump contradicting what WHO said and threatening to withdraw from the WHO. We had anti-vax movements, and people were confused. But when we went back and reminded them of all the other things that the WHO does, World No Tobacco Day, World Hepatitis Day, World Blood Donor Day, when we reminded them of 14 major diseases that have been controlled by vaccinations, suddenly the lights came on. Suddenly people realized that we have controlled some of the world's worst diseases in the past very, very effectively. So maybe there is something in what we're saying. And so that was very counterintuitive, that rather than just focus on COVID, we found that we needed to spread the message about a whole range of WHO activities, even in the midst of the crisis. And of course, initiatives like the COVAX initiative, sharing vaccines with poorer countries, was important. All through this, we've been able now to get data that's showing trust in the WHO is rising. It rose from 2020 to 2021. It's even higher than the United Nations and quite a lot higher than the European Union. Edelman tells us that trust in the WHO has increased in 15 out of 28 of its major countries that it studies. You'll see, ironically, that trust in China in the WHO is among the highest. And very sadly, trust in WHO in the USA still remains quite low, right down close to Russia. So there's still work to be done. What didn't work? Routinized presses, as they call them, press conferences. I'm not saying press conferences don't work, but when they become routinized week after week and the same things are being said. But also we found planning that was based on too little data, which we faced in a lot of the time. We found that it's very important to have formative and summative evaluation. Formative being the evaluation you do before you begin. You need to have baselines. You need to have audience understanding in order to target well and to compare later. But in particular, the lack of outcome and impact data was one of the major things we found that caused problems in the beginning. We also found that our own internal communication and engagement didn't work so well. Only 41% of staff activated their workplace profiles. Only 15% opened emails on average, and so on. The final word I wanted to say in summing up is data is important, but be very careful of raw numbers. Measurement gives us raw numbers. Evaluation is interpretation of those numbers and drawing insights. So this chart is the website visitors for the first half of 21 and the second half of 21. And you'll see that in the first half of 2021, the WHO had almost 240 million website visitors. But in the second half of 2021, they only had 142.5 million visitors. So that might indicate failure. But of course it's not. We have to interpret that data because in the earlier days of the pandemic, the WHO website was one of the few websites to go to for COVID information. And then, of course, later in 2021 and into this year, there is an increasing range of sources. There are hundreds and hundreds of national websites and specialist websites. There's also information saturation, that much of the information is out there, and perhaps even some COVID fatigue. And so measurement gives us numbers, but evaluation is the intelligent interpretation of those numbers to gain insights. I need to summarize. These slides will be made available through AMEC, but what I've really said is we've got to get beyond activities and outputs, where a lot of our work goes, to be able to identify outcomes and impact. And we need to know the difference between outputs and outcomes and impact. We must avoid substitution error, and I've endeavored to show you that it still occurs. It's still being provided even in media analysis reports that are being distributed. We need to recognize for our own welfare that inputs, activities, and producing outputs, in doing that, communicators are a cost center. It's only when we produce outcomes and impact that communication becomes a value-adding center. And I'm sure every one of you wants to be working at the value-adding end of your business or your organization, not just simply be a cost center. We've got to recognize that communication is a two-way process. Stakeholders, communities, and society are not just targets or audiences. To understand outcomes and impact, we have to be listening. We have to be harvesting information and listening to our stakeholders and our audiences to hear what they're consuming, to hear what they believe and trust, to hear how they are using or if they are using our information and how they are acting as a result. And to do that, there is no silver bullet. For many years, the measurement and evaluation sector has looked for a magic metric. But what you'll see in this case study is we had to process mountains of data. We had to have the skills and tools, hence the internal learning, to be able to use multiple data sets to track the progress from inputs to outputs. And therefore, learning. Learning became key. The MEL model. We had to learn from evaluation to gain insights, but in order to do that, we had to learn about evaluation. We had to learn more about evaluation through capability development. So I hope the MEL model and the Dissected program logic model will give you some things to think about in the future. Thank you.